Hello, my name is Reena Chokshi and I'm a third-year gastroenterology fellow at Washington University in St. Louis, Missouri. Together with my co-authors, Christine Hovis, Thomas Hollander, Dana Early, and Jean Wang, we are proud to have our paper, Prevalence of Missed Adenomas in Patients with Inadequate Bowel Preparation on Screening Colonoscopy, accepted for publication to Gastrointestinal Endoscopy. The idea for this paper came about from our own uncertainty regarding appropriate follow-up guidelines for patients who present with inadequate bowel preparation on screening colonoscopy. The current guidelines from the American Society of Gastrointestinal Endoscopy and the American College of Gastroenterology suggest that bowel preparation is considered adequate if it allows detection of polyps 5 millimeters or larger. The current follow-up recommendations in these guidelines assume adequate bowel preparation, but despite our best efforts, still about a quarter of patients present for colonoscopy with inadequate preparation. It is unclear what to do or recommend for these patients in terms of repeat screening or surveillance. Clearly, the disadvantage here is the potential for missed lesions, such as adenomas or malignancy. Our study sought to assess the prevalence of these missed lesions in this specific patient population. To that end, we performed a retrospective review of colonoscopies completed at our outpatient endoscopy unit between August 2004 and August 2009. To be included, the colonoscopies had to be performed for average risk screening indications and be documented as having either poor, inadequate, or unsatisfactory bowel preparation. Our endoscopy database uses the 4-point Aronchik scale of excellent, good, fair, or poor preparation, and endoscopists are instructed to select one of these from a drop-down menu at the end of the examination. Bowel preparations that were considered fair were not included because occasionally these can be adequately suctioned or irrigated to give an adequate overall examination. Alternatively, if patients were documented to have inadequate or unsatisfactory preparation, these were also included. Examinations had to be completed, at least to the cecum, and all polyps that were detected had to be removed. The endoscopists included 34 faculty gastroenterologists as well as 1 faculty colorectal surgeon. A total of 373 patients met inclusion criteria for analysis, and data was collected for repeat colonoscopy through August 2010 for each patient. Repeat colonoscopies were completed at our institution in 35% of patients within the study timeline. Of those, 33.8% had at least 1 adenoma detected that was not found on initial examination. Overall adenoma detection rate was 43% in males and 27% in females, and this was not significantly impacted by either trainee involvement in the exam or use of high-definition technology. Of the patients in whom an adenoma was detected, 31% had no polyps seen on initial examination, and mean time between colonoscopies was 340 days. High-risk states were found in 18% of the repeat cohort. These were defined as having at least 3 adenomas, having an adenoma at least 10 millimeters in size, or having adenomas with villous or dysplastic features. Of the patients in whom high-risk states were found, 25% had no polyps found on initial examination, and mean time between colonoscopies was 271 days. This short interval suggests that these polyps were likely missed on initial examination. Per adenoma miss rate was found to be 47.9%, with 99 adenomas seen on initial examination and 91 on repeat examination. 64% of missed adenomas were noted to be in the proximal colon. Similarly, 80% of advanced adenomas were missed in the proximal colon. A total of 18% of patients in the repeat cohort would have been given different follow-up recommendations if their lesions had been found on initial examination. 2/3 of these were because initial examination only elicited no polyps or non-adenomatous polyps, and 1/3 of these patients, because of the size or number of adenomas found, would have merited shorter surveillance intervals. Overall, we found a high frequency of missed adenomas and high-risk lesions in our patient population. We believe that confining our data to outpatient average risk indications in the setting of poor, inadequate, or unsatisfactory preparation gives a fairly accurate estimate of the true missed adenoma prevalence in the screening colonoscopy population. While our per adenoma miss rate of 47.9% is alarming, it is also very interesting that 18% of our repeat cohort would have been given different follow-up guidelines based on their initial examination if their lesions had been found. Moreover, the fact that the majority of the missed lesions were seen in the proximal colon suggests that it may be best to abort colonoscopy in the setting of inadequate bowel preparation, rather than subject a patient to the risk of a full colonoscopy that may result in missed lesions. In these situations, it would be better to repeat the colonoscopy and achieve optimal preparation. Future research aimed at validating this approach would certainly help our understanding of how best to manage these patients.